Okay. Uh, okay, I think we are on air. Good morning and welcome everyone. Again, I'm Dr. Mohammed Gill. All sounds good? We are good to go? Can you hear me? Okay. All right, so let's begin. The topic today is anemia and blood transfusion. It seems, and it always been taken by our staff as a very simple problem to solve, but with more regulations and with, as we move forward with more studies, it gives us, takes us to a point where we had to intervene and put some restrictions over the knee-jerk response to the anemia treatment and so forth. So, and also I would like to share with the attendees of Global Rounds that I have sort of started this series of lectures every month where I'll be discussing a topic of common interest and which is in practice and common diseases in regards to the basic science as well as practice. We will be doing it in a sort of educational seminar style, with starting with questions, and then we will move towards the practice principles and updates. So with that, let's begin. This is a 75-year-old woman who presented to the emergency room with confusion, fatigue, and feet numbness. She is referred to the hospital in the past few days back for the pre-employment, and she had been advised by her orthopedician to have knee replacement. But while this process was underway, her family brought her with the confusion, fatigue, and feet numbness to the emergency room. Patient was previously healthy and had normal memory months back. And examination-wise, her pulse 84, blood pressure 140/80, respiratory rate is 18. Her mucosal pallor, tongue is smooth upon her HENT exam. And her nervous system exam revealed decreased sensation in stalking distribution. Moved to laboratory tests, WBC 3.2, hemoglobin is 8, and MCV 105. Platelets 82,000, and blood smear show macroalveolocytes and hypersegmented neutrophils. Next slide, please. So what's the best next step? And I'm sure all of us have come across this situation of a patient who is in the hospital or in the clinic. Anemia is borderline yes and no. Should we give transfusion, yes and no? And if patient has a cardiac disease, we can get carried away with ischemic heart disease. If hemoglobin is 7 or 8 and patient has walked to your clinic, going for surgery, has cardiac history disease, cardiac history, and now we come to this crossroad of whether shall we transfuse the patient and get it over with, or shall we have to investigate further, and how much time we have from our consultation, and then comes in like how much time we want to spend and other factors come into play. So therefore I made this question with the real clinical scenario as option A is transfuse 2 units of fat red blood cells Option B is check B12 folate level before transfusion. Option 3 is perform a bone marrow biopsy. Option D is check B12 folate, iron studies, MMA, intrinsic factor parietal cell antibodies. Option E is check iron studies and hemoglobin electrophoresis. Just think of the answer. And next slide. The correct answer is D. Can we go back to the answers? Okay, thank you. So if you look at the answer D, we decided to go ahead and investigate all the pretty much causes of anemia in a otherwise physiologically okay lady with nervous system signs and symptoms and anemia. Next slide, please. This patient is suffering from pernicious anemia. I'll quickly give you an overview what pernicious anemia is. It is a parietal cell antibody mediated, leading to the inflammation of gastric antrum and loss of intrinsic factor, which is essential in B12 absorption, and usually B12 deficiency purely, its MCV is 113. So if you look at the question, if you go back, the patient's MCV was 103. So it becomes a little complicated. If you look at the labs, MCV is 103. And if you look at the patient's blood cells indices, the MCV of our patient was 103. However, if it's a pure B12 deficiency, MCV should be around 113. So therefore, it's essential that we look at every aspect when we look at a blood test with the lens of looking for differential diagnosis for anemia. What could be the reason for this microcytosis, macrocytosis, and that leads us to the point where we would like to know what are the other red cell indices important for us to remember in order to have a glance on CBC and quickly reach to a shorter list of differential diagnosis. Before we move forward, just quickly, in case of B12 deficiency anemia, the folate is almost usually always involved. It is, because folate and B12 metabolism and their use in the bone marrow to synthesize hemoglobin is codependent. Folate is activated by B12, vitamin B12. Folic acid is vitamin B12, and vitamin B12 uses homocysteine as coenzyme to activate folate. So folic acid, when it's activated, it incorporates into DNA synthesis and RBC manufacturing in the bone marrow. Next slide, please. So what is anemia? It is a reduction in one or more of 3 RBC studies. Believe it or not, when we colleagues sit down, we talk about who knows definition of anemia. Reduction is in hemoglobin and hematocrit, usually the answer. So RBC count, hemoglobin, and hematocrit. One or more reduction in one or more of these indices, anemia. hematocrit is volume occupied by RBC in 100 ml of blood. Surgeons love to call out hematocrit or are interested in hematocrit. RDW, we usually overlook RDW written in the CBC. RDW is the red cell distribution width, and which means that if there are a lot more different sizes and shapes of RBC, the RDW will be high. So then in our mind, it should take us to a differential diagnosis of, okay, B12 or iron deficiency and so forth. Haptoglobin, I just want audience to remember, it's a liver-generated protein, and haptoglobin is a carrier of free hemoglobin, and haptoglobin level are important when there is hemolysis. Platelets and reticulocyte counts are relevant in case of anemia because it tells us that there is a fault in manufacturing all blood cell lines, or is it just hemolysis or other factors like lead poisoning and so forth. Next slide, please. So CBC, usually it's worthwhile getting differential in case of a new patient, especially. Always get CBC, complete blood count with differentials. It gives us a quick glance can give us a list of differential, and we can narrow it down. MCV is very important after knowing hemoglobin and hematocrit. The mean cardiac volume normal is 82 to 98. The MCHC, which is the concentration of hemoglobin present in an RBC. Vessel distribution, width important if there are different size and shapes of RBC, and reticulocyte count. The reticulocyte count is looked at as response of bone marrow in case of a reduction in hemoglobin. Usually a reduction in hemoglobin leads to hypoxia. Hypoxia leads to a response by bone marrow in form of high reticulocyte count. And if that's not happening, then which means that something is at foul play in the bone marrow. And platelet count and our WBC count also, their cell lines are affected when there is a problem in the manufacturing of all cell lines. Next slide, please. Quick differential microcytic anemia. So when we have a patient with anemia, the next step is to look into the size, usually normocytic anemia, micro or macro. Normocytic anemia could be due to bleeding, could be iron deficiency, anemia of chronic disease, bone marrow suppression. These are the top ones. Really most common, very, very common are these causes. Iron deficiency anemia, very well can be microcytic and macrocytic. Remember, patient does not come as a textbook picture. The picture is always in the middle of somewhere microcytic to normocytic or normocytic to macrocytic. It's our job to narrow it down stepwise fashion. So what we know is microcytic. When we move to the next step, please go over this slide. You probably have given the handouts. Next slide, please. So when we do the evaluation, after we have looked at the MCV, we can go down further. Now, if MCV is less than 80, most likely patient either have iron deficiency anemia, thalassemia, anemia of chronic disease. So with MCV less than 80, anemia of chronic disease, usually not very common. is either iron deficiency anemia or thalassemia. Now with thalassemia, it's a hemoglobin synthesis defect where the globin chains are defected, and we're not going to do much detail of it. Thalassemia minor and major, and thalassemia trait, and it's related to anemia and usually red cell distribution with its normal. Iron deficiency usually is marked in MCV, and when we have low MCV, we look at the ferritin level. Ferritin is also anemia of acute phase reaction. Sorry, let me correct. It's a factor of acute phase reaction, and could be high in acute inflammation and chronic disease process. Patient is in the hospital for long. Ferritin usually is high, so therefore we go into further testing for iron deficiency, TIBC, iron level, and that will differentiate the iron anemia of chronic disease from iron deficiency anemia. So this is a good flow chart to quickly get to a shorter list. MCV, as you can see, there are normal MCV. There are many reasons for it. If, for example, MCV is close to 100, you go to hypothyroidism and infections or B12 folate deficiency as well. And MCV is higher, 113 or more. That's purely vitamin B12 folate. And hypothyroidism, usually MCV lies around 100, 110. And reticulocyte count should be high in case of non-B12 folate deficiency, and myelodysplastic syndrome and so forth. Next slide. So this is our patient. The pernicious anemia is actually a B12 deficiency anemia, and pernicious anemia, hematological findings. We just discussed the symptoms of anemia are pallor, lemon yellow skin. There are neuropsychiatric findings, numbness, paresthesia, usually dorsal common tract of spinal cord are affected first and are prominent. Patients could present with dementia and psychosis, which is not a typical finding of, for example, somebody 59 years of age coming up with these symptoms. We must look into pernicious anemia or B12 folate deficiency. Ataxia, weakness, spasticity, glossitis, other epithelial changes here, and why that happens. Of course, B12 folate, they are responsible for the new cell synthesis, epithelial synthesis, and functions of neurons. So that's the base pathology behind that. Next slide, please. So now, if we have macrocytosis and anemia and all these findings, so let's differentiate B12 deficiency from folic acid. In case of B12, the serum folate should be normal, or could be high because it's not been consumed. And in folate deficiency should be low. And remember, these are nutritional deficiencies. So the definite test to differentiate between B12 and folate is MMA, a blood test. and plasma homocysteine. Plasma homocysteine is a coenzyme consumed by B12 to activate folic acid. Next slide. The microcytic anemia, quick differential iron deficiency from anemia of chronic disease. You can see at the quick table, if you remember that. Usually in the clinic or the hospital, it's very helpful to remember these. TIBC, that's total iron binding capacity. So that's the capacity of transferrin that carries the iron in the bloodstream. So if the capacity means it's all unloaded, it's empty, there are too many spots for transferrin to carry iron, means there's iron deficiency, and then serum iron level. These tests are helpful to differentiate it from anemia of chronic disease, because in anemia of chronic disease, the ferritin would be high, and which is acute phase protein produced by liver. And in case of iron deficiency, pure iron deficiency should be low. But remember, it could be mixed up. Patient has other things going on and could also have iron deficiency at the same time, and could also have B12 deficiency at the same time too. Therefore, when patient presents and there is a little bit mixed picture, we should do all these basic tests. And maybe we can replace the deficiencies and correct that patient if we have time, instead of jumping towards blood transfusion. And what we will do is, jumping towards blood transfusion, we will just overload with unnecessary aspects and unnecessary components of blood, and we are not actually addressing the reason of anemia. Next slide, please. I think we discussed that. Next slide. There are other causes for low blood cell count, and just have a quick look with liver disease, hypothyroidism, chronic kidney disease, the disseminated intravascular coagulation, thrombotic thrombocytopenia purpura. But these are severe diseases, and we can easily catch them when that process. I think patients pretty a lot more sicker. The mechanical valve is a big mechanical damage to RBCs and so forth. Next slide, please. A quick look at RBC life cycle for us to have a little refresher. Red blood cells are produced in the bone marrow by erythropoietin stimulation, which is regulated in our homeostasis using globin from old RBC, death of old RBCs, the globin and heme comes back for the recycling and the production of new RBCs. RBCs go into spleen and other organs where macrophages find them after, typically life cycle is 120 days. A typical RBC dies after 120 days, and there's actually first the shape gets distorted, and macrophages and spleen they filter them out. Okay, this is normal size and shape, pass, and RBC, which is stiffer, cannot do rouleau formation. The side they have a different shape, and they get caught, filter out, they're broken down, heme and globin, and you can see the flow chart. The heme is taken up by transferrin and turned into ferritin, and then transferrin take it back. Heme, which has the iron, take it back to bone marrow, and the globin is broken down into amino acids and so forth. Next slide, please. These are some of the beautiful pictures. I thought that we put some color into our presentation. See hemoglobin C and S, that's sickle cell disease. And these are spur cells in liver disease, the spherocytes and hereditary spherocytosis, the lead poisoning, where there is basophilic stippling, the microangiopathic hemolytic anemia like TTP, like thrombotic thrombocytopenia, DIC, and hereditary eleptocytosis. In the exam of board exam or USMLE exams, it's common to use these photos with the clinical scenario for the diagnosis. Next slide, please. Hemolytic anemia, quickly, a quick look. Hereditary spherocytosis. The spherocytes are round tennis ball-like shape, so macrophages and spleen don't like them. They think this is a dying RBC or abnormal, need to be filtered out, so therefore hemolysis occurs beside their inability to be have a flexible cell membrane. And hemolytic anemia without spherocytosis are different hemoglobinopathies. We just looked at 6PD deficiency and other enzyme deficiencies. They make usual blister, like there's a blister on the side of the RBC when we look at the thin film, peripheral film. Spur cell and liver disease, and we just discussed. I just want to mention, a lot of times, especially for students and residents, it's worthwhile if they see a patient, if they are suspicious that they have one of these interesting kind of anemia, go to the lab and take a look at the peripheral film. It's very easy, very quick. Drop of blood can give you a lot of information and very interesting information. Next slide, please. Choosing wisely, that was my main reason for preparing this presentation. There is a handout that I had attached with the presentation about choosing wisely. The Society of Advancement of Patient Blood Management has given 5 points how to make determination when are we going to transfuse and when we are not, and advised avoid transfusion. So the first one is avoid transfusion for pharmacological treatable anemias. Now, if the patient comes in like our patient, like I have given you an actual clinical scenario when I started my presentation, the quick fix is to just order 1 or 2 units, and other things are okay, clear the patient for surgery. But that's not a right thing to do. The right thing to do is to go down to the reason of anemia, and that will be achievable within a day or 2 by just looking at the details, the iron, the B12, the folic acid. The second point is avoid excessive blood draw. It's called iatrogenic anemia. Believe it or not, patients do get anemic by daily blood draws. So I'm a hospitalist, and I do have this habit every day. My patient, needed or not needed, TBC, CMP, and going before writing orders for others for tomorrow, 6 a.m. You don't have to do that unless patient really need that close of the monitoring. So please make sure that you avoid iatrogenic anemia. Prevent acute blood loss, and that's for surgeons and for obstetricians. Restrictive use of plasma. Also very, very common thing, and sometimes that need to be discussed with the surgeons, that the INR is going to be okay. We don't really have to do plasma. We can just, and it depends on situation by situation. If patient is on how high is the INR, and what kind of surgery they want to do. Talk to the consultant about that. Next slide, please. Now, what is acceptable hemoglobin level? 7, 8, it's debatable between 7 and 8. Less than 7, you can debate a patient who is chronically ill or acutely ill with a severe disease and has cardiac issues. Yes, it's okay to transfuse and then look into the differential of anemia. In stable patient, transfusion may not be necessary, even if hemoglobin 7 to 8 gram per deciliter. So that's your usually a mark. 7 to 8 is okay. And if patient has ischemic cardiac disease, that you are worried that patient might get angina because of anemia, then you can transfuse at that level as well. Transfuse minimum number of units. Another common mistake we make, knee-jerk reaction, transfuse 2 units. Not necessarily. Look if 1 unit is enough to move forward and improve the nutrition of the patient, see what that do. And in case of chronic kidney disease, erythropoietin is really important not to forget. 7 to 8 gram is usually safe. And these are all these advices by choosing wisely. I have this paper attached to the presentation. I hope that you all have it. And the last point is again to improve nutrition and erythropoietin use, well indicated. Next slide. For our inpatient practicing doctors, trolley is something that is common than we think that it is. And it is it's called transfusion-related acute lung injury. And how do we diagnose it? Acute non-cardiogenic pulmonary edema following or during transfusion of blood products. And so the patient is receiving blood transfusion, otherwise does not have established heart failure or pulmonary edema, or has a clear reason for pulmonary edema, goes into respiratory failure, pulmonary edema, following blood transfusion, usually the same day or after or during the blood transfusion. It's called trolley. It's a medical emergency. Patient usually gets intubated. You need to call the intensivist on board and manage patient. It's a cell-mediated immune response. That's the basic behind pathology. And it could be antibody antigen complement system activation. It's basically the allergic reaction in a way you can say that to a foreign blood product. Usually immediate acute pulmonary edema following transfusion and treatment. Stop transfusion and call the intensive care team. And with this, I think we end our presentation. Next slide. Thank you. Questions, comments, please.
Well, thank you very much, Dr. Gill, and excellent review of anemia and and some of the management issues that we often face. I'll start with a question that relates to practice of remote medicine, particularly in resource-limited environments. It's not unusual in the practice of global telemedicine for a laboratory value that's limited to hematocrit alone, using small kind of mini lab testing devices that are now part of the kits that are used for delivering telemedicine and triaging patients. So in the scenario where we know we have a patient with a hemoglobin hovering around 7, maybe a little bit below, but we don't have a differential count, we really don't have the advantage of any other complex lab. So all we know is that we have a patient in front of us with a new anemia. Let's assume that's new, who's moderately symptomatic, but not crashing. If we're really stuck there and have no other resources, including transfusion, is there a scenario where we could recommend a presumptive treatment of this anemia with supplements such as B12 or iron, if those are on hand at the village or the facility where the patient may be? I'll mute.
Very, very good point. Excellent, actually. And I was mentioning early when I started speaking, usually this is not necessarily in remote cases, in our urgent cares and also our clinics here in the US, where we do have labs, but we are thinking whether shall I go for detail or not. So I think the approach should be, it starts from history. That's like obstetrical history, the menstrual bleeding, blood loss, any history. So history is really important. Quick review of blood loss or nutritional challenges. I'm from Pakistan, and where I grew up and was born, and went to first year of my house officer appointment after medical school. And what you have stated is exactly what the situation we were in. So how did we do that? We took good history, we did a good exam, rule out iron deficiency by the angular stomatitis, the spoon-shaped nails, the strawberry tongue or smoothing of tongue, the neuropsychiatric symptoms, the symptoms of blood loss, the signs of hypothyroidism on the clinical grounds, the liver disease, the kidney disease. And these are usually the topmost reasons for someone to have anemia and without even looking at CBC indices. However, the hereditary spherocytosis or sickle cell, usually symptoms start coming at age of 20 and so forth, sometime age 10. And it's usually, if someone comes in age 21 and has symptoms of anemia, it's usually the hereditary causes. And that should have us send the patient for further testing, if this is the case, to either hematologist or look at the blood film or have the bone marrow studies done. But in case of common nutritional deficiencies, it could give us a clue by just looking at the patient. Doing good history and good physical exam can really narrow it down, answering specifically to your question. Did I answer your question?
Great.
Hello?
Any other? Oh, I'm sorry, Dr. Gill, I lost a bit of connection. Apologies if I stepped on the end of your answer.
No, I think it was a little frozen on my side. Technology.
Okay. Absolutely. Okay. Do we have any other questions for Dr. Gill? Please don't be shy.
I have a question, Dr. Falk here.
Great, thank you.
One of the issues in surgery is and in trauma, and maybe I missed your comments here, but in the chairman of our department of surgery where I studied was big in this is, when do you need to transfuse somebody? What's your indications for transfusion? Now, maybe you covered that and I didn't, but it's a interesting issue. I mean, I know it depends on the circumstances and the chronicity of the anemia and everything else, but in the trauma business, that's a big issue.
So the two things I can answer, and based on my experience as an internist and hospitalist. So the choosing wisely was actually more. It is addressing to prevent as much transfusion as you can. And it also advises to involve the patient in the process. Now, there are two reasons that usually hemoglobin around 7 or 8 we can transfuse. Number one, either patient has ischemic heart disease, and we are worried that the coronaries will not get enough oxygenation because of lack of RBC count. So that's the idea behind it. So we want to make sure. The second reason is the intravascular volume. If patient is in trauma bay after MVA, motor vehicle accident, or whatever, any accident leading to blood loss, that's an indication that we can replace it, because you're not only replacing volume, we are replacing RBCs. And the third is, if patient is going for the elective surgery and it's a complex, long surgery, and we know that we're gonna have possible blood loss of more than, I think it's 250 to 300. There are surgeries that could lead to more than 50 or 100 ml of blood loss. Keep blood type and cross-match ready in case that the transfusion will be needed. These are the top three reasons, top of my head, that we have transfused, and we are still in compliance with choosing wisely.
Thank you.
So going forward, this is how I have planned. We will be, if the grand rounds, everyone in the grand round is okay with that approach, I will be bringing in a common clinical scenario from certain systems, like, for example, next month I plan to do diabetes, and there are so much updates and so many points in management. We will be discussing that. So we will take a clinical scenario and we will present it to our audience, and we will go one by one different challenges in management of that particular disease pattern, and have more clinical discussion and practical approaches to our disease patterns. This is gonna be, I'm gonna be trying to do that as series of lectures. Are we at the time? Is we at 8:46. We still have 14 minutes.
So yeah, thank you for the answers, and also for explaining and sharing the format. Excellent and very helpful. So, any other questions, concerns? Again, either raise your hand or just speak up and unmute, and we'll go from there.
Dr. LaRue, I see you raising your hand. Do you have a question? I think I just have a comment to share about a case, and thinking about the complex physiology and the ability of our human systems to survive, and all the secondary systems that kick in with either acute anemia or chronic anemia, oxygen delivery systems, cardiac output. So I just would share, it's an interesting thought process for me. After doing this for 34 years, my lowest hemoglobin in my career, with kind of an acute on chronic GI bleeder in a 20-year-old female in the emergency room, was 1.5, and she survived. I just share that.
That's very low.
It's very low. I don't think, I don't know if anyone has another story like that, but just to think about the compensation of our human systems.
What'd you do?
Is fascinating.
What did you do for her? What did you do for that patient?
That was in my second year of residency. And I remember, I got my ER attending very quickly at the bedside with me. And so it's interesting. She was an acute on chronic. So, even her heart rate, her compensation systems were fascinating. Her heart rate was, say, 100. Blood pressure was, 90 systolic. So she somehow was getting through this. But of course, we transfused her, and I think she was she ended up with an endoscopy and had a, peptic ulcer disease. But I suppose to your great question about when do you transfuse, what is that critical moment where someone will decompensate and go on to, much worse things than recovery. But so yeah, she tolerated a very low hemoglobin and survived.
The answer to that is that it depends on the circumstances. Like you say, a chronic situation is different. One of the things that I've encountered here and there that's always interested me is when we have a Jehovah's Witness in a trauma situation, and and the situation that I encountered, which was because it was a child who had been in a bicycle accident. I think he was 7 or 8 years old, and he had ripped open his pelvis, and I don't remember the exact numbers, but he was just really anemic, and his parents were Jehovah's Witnesses, and did not want us to transfuse him. So I have a quiz for the panel. What do you do in that circumstance? This is a question for the other doctors. You got an 8-year-old child who's a Jehovah's Witness, and then there's a second case that's part of this quiz, and that is, what if it's a 25-year-old woman who's a Jehovah's Witness, and it looks like she might die without transfusion? So those are the part A and part B of this quiz. Dr. Gill, what do you think?
I know. Oh, actually, it is common. Jehovah's Witness is one of the challenges, and I do remember when Dr. Laura was, I want to say it, Dr. I lost your name. Sorry.
LaRue?
Okay. Dr. LaRue. Okay, I apologize. Patients as Jehovah's Witness, they are not going to let you give them any blood products. So we are just depending on only few things. One is option of erythropoietin, the procreate, and iron injections that I have managed in the past, if iron deficiency. Usually, if it's a girl who's Jehovah's Witness, the reason for blood loss is one of the contributing factors is the gynecological blood loss or obstetrical blood loss, beside other reasons. And if someone has a hematopoietic issue or bone marrow level issue, that's a different story. Like we can check reticulocyte count if it is, are they high? If they're high, the bone marrow is functioning most likely. So in that case, can focus on nutritional deficiencies and approach that way. But was your question, did you ask that if patient is dying?
This is an acute situation. This is a person in the ER who is bleeding to death. And they're Jehovah's Witness.
Oh, okay,
So
sorry, I missed that one.
First of all,
No,
there's an adult
that's
patient, there's a pediatric patient. There's adult and pediatric. I'm just curious what.
Well, it's a patient who is adult and has a capacity to make decision. It's a question of ethics, and we have to unfortunately honor patients' wishes.
Yeah.
And I have been to that situation. We did not transfuse. We can replace the intravascular volume by fluids, and again, do even that acute situation, give procreate, diagnose the reasons. Maybe we can correct it in time while patient.
How about the child?
To child, that's a capacity by proxy, right? So patient's wishes by proxy. Now, that's a question for them. I think what I will do, I will call social worker and my ethics committee from the hospital.
I can tell you what we did.
Okay.
We got a court order to transfuse the child.
Oh,
Yeah.
And I think that different people might have a different idea about that, but the parents were actually kind of relieved. It took it off of their back.
yeah.
But so anyway, in my practice over the years, for children, we won't let them die for lack of transfusion without a court order. If you're an adult, that's fine if that's what you want to do. That's just my own personal opinion about it. But it is an ethical issue. It's kind of interesting to consider in terms of parent rights and so forth. And it's controversial. Yes, sir.
It's controversial, yeah. Very well it is. Yeah.
David, what do you think?
Dr. Falk? I'd ask is it Dr. Falk, Larry, the surgeon? Larry?
Yes. Yeah.
Oh, Larry, how does that process work in the emergency room? Do you have the judicial system is set up to take care of that? How does that work practically?
Yeah, there's a judge on call, and they can do it over the phone and then follow up with paperwork later.
Oh, okay. Thank you.
Some of these ethical issues are pretty interesting. I have another one to tell you about, but it's not had to do with bleeding. But you encounter problems where there are real issues, whether you're going to let a patient die or you're going to do something, and it's tough sometimes.
Wow. Thanks for sharing that. That's fascinating.
Yeah.
I'll comment on that in the general category of the lowest hemoglobin you ever saw. So this is a 40-ish lady that presented with weakness and some shortness of breath, obviously pale in the general, and since we're talking about anemia, and was just added on to the regular office schedule in a primary care clinic in which I was working, and proceeded to obtain a blood count, and her hemoglobin was in the low 2s, and lo and behold, she turned out to be a Jehovah's Witness, and also declined hospitalization for at least support, hemodynamic support. She was orthostatic, hypotensive, et cetera, but declined hospitalization, declined transfusion. And but she did allow us to do some advanced labs, and found her iron to be essentially, serum iron to be nearly non-existent, and ferritin. And it took probably, with iron supplements, probably took, if I remember correctly, a few months. It was amazing how well this was corrected. And she did consent to upper endoscopy, and turned out that she had an NSAID-induced gastropathy as her hemoglobin dropped lower and lower. The headaches for which she was taking ibuprofen were getting worse and worse. So her ibuprofen dose was going up. And of course, her kidney function was going down, which just contributed to the whole vicious cycle. But she actually did well, and stopped taking her ibuprofen. Her headaches went away, and her hemoglobin normalized. Took about maybe 2 or 3 months.
What did you say her hemoglobin was to start with?
In the mid 2s.
Okay.
And she walked in. She drove to the clinic on her own. So whenever I see somebody who looks a little feeble in an automobile that might be swerving and maybe driving a little erratically, I sometimes wonder what their hemoglobin might be. So
That also underscores the point that the chronicity of the anemia is all important.
absolutely.
You have a chronic blood loss from a gastric ulcer is one thing, and if you just got shot in the femoral artery, that's something else.
Absolutely. Okay, any other questions, comments? Really do very much appreciate your attendance and interactive dialogue here. This is great. So hearing no other comments or questions, I think I'll go ahead and hand it back to you, Quang. I want to thank you, Quang, and the volunteers at Global Offsite Care who work hard to support this program and make the lives of our patients and our professional lives just that much better, and also to deliver some CME to those who maybe are a little behind on that CME. And I think that's a nice gift that the Global Offsite Care has integrated into this program for years now. So with that, Quang, I will hand it back to you.
All right, thank you, Dr. Piquia. So if there's no more question for Dr. Gill, I will go ahead and conclude the global grand round for today. Thank you so much for everyone for coming, and a special thank you for Dr. Gill for your insightful presentation, as well as Dr. Piquia for helping to moderate the presentation today. So and once again, please don't forget to fill your CME form if you need it, and have a good rest of the day. I'll see you guys.
Thank you, everyone. Thank you very much.